Hello friends, today we are going to discuss about psychogenic non-epileptic seizures, also called as pseudo-seizures. I am Dr. Suresh Padadmat, Professor of Psychiatry, working at NIMANS, Bangalore. In this video, I'll be discussing about psychogenic non-epileptic seizures, how to define them, what are the clinical signs and symptoms, diagnosis, differential diagnosis, comorbidity, and management. Before we start discussing about pseudo-seizures, let's discuss about seizures and epilepsy. Seizures can be defined as a sudden uncontrolled electrical activities in the cortex, that is in the brain, which can cause changes in the behavior, movements, feelings, and also at the level of consciousness. That is seizures. Then what is epilepsy? Epilepsy is defined as two unprovoked seizures occurring more than 24 hours apart. So once you know about the seizures and epilepsy, now it is easy to define psychogenic non-epileptic seizures. Why is it called as psychogenic? Why it is called as non-epileptic? Let's look into this definition. Psychogenic non-epileptic seizures is a term that refers to recurrent paroxysmal episodes that mimic epileptic seizures without cortical electroencephalogram changes. That means there is no electrophysiological changes occurs here. In brief, I can say is it is not a seizure, it is not an epilepsy, and there are no EEG changes seen. That is the clear definition of psychogenic non-epileptic seizures, also called as pseudo-seizures. In late 18th century, Charcot first defined it as a non-epileptic seizure as a clinical disorder, calling it as a hysteria, that is, wandering uterus or a womb. Further, Sigmund Freud also made a very important observation. Even today, it is considered to be one of the hypotheses. He said, one or more occurrence of premature sexual experiences or trauma that leads to pseudo-seizures or psychogenic non-epileptic seizures. It is also called by various names such as hysteria, hysterical seizures, psychogenic pseudo-seizures, non-epileptic seizures, Hystero-epilepsy, hysterical pseudo-seizures. So it is called by various names. But however, the term which is internationally accepted at this point of time is psychogenic non-epileptic seizures. Here, non-epileptic seizures are involuntary episodes of movements, sensation, or behavior that do not result from abnormal cortical discharges on EEG. That means, very important exclusion criteria is there should not be any EEG changes from the cortex. The psychogenic non-epileptic seizures can mimic any kind of epilepsy. It can mimic focal seizures, it can mimic GTCS, complex partial seizures, or any other kind of seizures. So sometimes it becomes very difficult to differentiate between real seizure and pseudo-seizure. The incidence of psychogenic non-epileptic seizure in the general population is 1.5 per 1 lakh population per year. Similarly, if you look at the psychogenic non-epileptic seizures in epileptic patient is 20 to 30%. Imagine if you go to any epilepsy clinic and who are under follow-up, if you check with them, at least 20 to 30% of them will have psychogenic non-epileptic seizure as a comorbid condition. Let's look into the clinical variables. Invariably, these pseudo-seizures presents either in the second or third decade of life, which is the most productive life of the time and also very stressful. This is the time, invariably, some of the people will decompensate. If you look at the gender, male to female ratio is 1:4. That means this pseudo-seizure occurs more commonly in females. Any occurrence of these independent pseudo-seizures after 40 years should be aggressively investigated for organicity. And these episodes can also be seen in elderly, dementia, in cerebrovascular accident patients, or in organic insult. Let's look into the clinical presentation of this psychogenic non-epileptic seizures. First and the foremost, they do not have classical stereotypical presentation. There will be no aura or prodrome. Invariably, they will be having varying ictal phase. That means the seizure period will change. Further, the pattern also will be changing. They will have bizarre movements, cyclical movements, asynchronous limb movements, and many a time they do not have any postictal confusion state. That means the seizures, so called seizures, will abrupt suddenly and there will be no disorientation. There will be no bowel and bladder incontinence. Further, these episodes occur in front of known people where the help is available. And these episodes can be suggested or induced by simple commands. Many a time, the patients with pseudo-seizures cover their body with dress, whereas in true seizures, the patients will not be aware, their clothes will be disheveled, and many a time they are exposed in public. And the patients, especially in pseudo-seizures, will have varying semiology and they will have presence of awareness. Sometimes many of them also will report they are unable to respond, but they know what is happening around the surrounding and they have the memory of the episode. Further, many of these patients will have forcibly closing their eyes. They will resist opening the eyelid. They are aware of the surroundings. And whenever the patient is in these kind of episodes, you can do a simple test, command test, telling that remember this blue code during the episode. You can tell 2 or 3 times. Once the patient is out of the episode, you can ask, I told something about the code. What is that code? He will easily say blue code. That means they are aware and also they are able to remember. Further, certain emotional situations or in a stressful situation, these episodes will be triggered. Many a time, the patients will have tongue bite only in the tip. That is a classical of pseudo-seizures. Further, these tonic-clonic movements will be classically pelvic movements in the form of forward thrusting. Sometimes dystonic posture, opisthotonus will be seen. Head will be classically having side-to-side movement. Many a time they will have prolonged seizures lasting from 30 to 90 minutes. Many a time multiple episodes. Seizure frequency will be very high. In a day, maybe 40-50 episodes. Many a time they are treatment resistant. And history of sexual abuse or physical abuse is well known. And also there will be a personal or family or a professional experience with the epilepsy patient. That means they would have seen somebody in the family with the epilepsy. And these episodes, so-called pseudo-seizures, never occur in sleep. They do not occur when they are alone, especially in the toilet, bathroom, because they have locked themselves, they know no help is available. Hence, invariably these episodes do not occur when they are alone. Rarely occurs in public in front of strangers. Imagine if a patient is in a public and nobody known people are around and is traveling in a bus, unlikely pseudo-seizure occurs there. Rarely it occurs in unfamiliar places. There will be, as I mentioned again, no bowel bladder incontinence and there will be no body injuries. Further, whenever the episodes are triggered, if you check the pupillary, there will be no dilation and also there will be no plantar responses. Let's look into the causative agent, that is etiology. The most easily understandable is stress diathesis model. Whenever they are in a stressful situation, they will decompensate by throwing a pseudo-seizure. And another one is a very important hypothesis was put forward, that is psychological, genetic vulnerability, shaping factors, trigger, and also prolongation factors. I'll be discussing this in the next slide. Further, there is another important theory which is talked about, psychodynamic model, where whenever the person has primary conflict, that is, there is a conflict between the id and ego, that is instinctual drive with the superego, then the ego will use pseudo-seizures as a defense mechanism. So that means primary gain is to resolve the conflict between the id and superego, and there is a pseudo-seizure. The secondary gain is avoidance of social responsibilities, job, occupational responsibilities, family related responsibilities. Those will be considered as secondary gain. Let's look into this important five-factor theory. Here in level 1, it is a psychological etiology, that is, the psychogenic cause, that is especially trauma. Level 1, invariably the person will have either sexual abuse or severe trauma. The second level is more of genetic vulnerability, maybe even neuropsychological vulnerability is classical. The third level is modeling. That means somebody in the family or in the neighborhood, or else the person has taken care of somebody who is having epilepsy. The third one, the fourth one actually is trigger. There will be a provocation and then maintenance. That means the secondary gains will maintain these symptoms. So, this is the easiest way of understanding about psychogenic non-epileptic seizures. Let's understand what is the cost of this pseudo seizure. Why should we be worried since it is not a seizure? But unfortunately, this pseudo seizure will bring the patient repeatedly to the emergency department for consultation, either to the casualty or in the middle of the night. Sometimes they will be admitted in the ICU. In US, it has been found one third of them get admitted in ICU. 50% will be admitted in the epilepsy monitoring unit. The admission may last from 3 to 5 days. Excessive investigation, CT scan, MRI, blood test, including electrolytes. Further, many a time the doctors would like to abort these episodes. They will start anti-epileptics. And many a time once they start, they do not stop it. That means the patient will be taking this anti-epileptics for years. Further, loss of manpower at work. Imagine this person has a psychogenic epilepsy and then is unable to go to work. So this is the cost. But however, when it was quantified in USA, the annual cost on psychogenic non-epileptic seizure is approximately 10 to 90 crore US dollars. That is the cost for a country. Let's look into the comorbidity with psychogenic non-epileptic seizures. Invariably, these pseudo seizures do not come alone. They come with their friends, such as anxiety disorder, major depression, somatoform disorder, obsessive compulsive disorder, PTSD, many a time even acute psychosis, schizophrenia, and personality disorders. That means whenever a patient presents to you with a psychogenic non-epileptic seizures, please look for comorbidity. Around 70% of the time, they will have a psychiatric comorbidity or neurological comorbidity. What is the commonest neurological comorbidity? Epilepsy. 20 to 30% of the patient who has epilepsy will have psychogenic non-epileptic seizures, cerebrovascular accident, and also organic brain syndrome. So these are the commonest comorbidity which is seen along with pseudo seizures. If you look at as I mentioned, this is just for the emphasizing in neurology, in epilepsy clinic, 20 to 30% of the epilepsy patient will have psychogenic non-epileptic seizures. And if you look at the comorbidity, that means there is no comorbidity, only standalone psychogenic epilepsy is there. It is only in 20 to 30%. You can consider them as stress-related psychogenic epilepsy. They are very few, 20 to 30%. Otherwise, invariably they will have psychiatric comorbidity or neurological comorbidity. Let's look into the differential diagnosis. The first one is sleep disorders, maybe narcolepsy, sleep terror, sometimes panic attacks in the sleep, syncope, movement disorders, cerebrovascular accidents, abortive seizures can also look like psychogenic epilepsy, true seizures, alcohol or substance withdrawal related seizures, and many a time autoimmune encephalitis like NMDR encephalitis. What is the management? For management, the first and the foremost rule is good history taking. Whenever the patient presents with uncontrolled seizures, where the medication is not working, please sit with the patient and the family members. Do a thorough analysis of the symptoms, when it occurs, how long it occurs, what are the characteristic, where it starts, how long it goes, what are the deficits present, how much disability is occurring in his life, and how many episodes occur till now. and there are huge in number, then check in the past 1 week how many episodes, per day how many episodes, when was the last episode. So this need to be documented. Along with that, if you are able to know from where it starts and whether it is generalized or temporal lobe epilepsy, you'll be able to make out. Further, if you require, EEG can be done. If you are in doubt, then you may consider doing video EEG, that is up to 24 to 48 hours continuous video EEG monitoring to be done. And it is considered as to be a gold standard for the diagnosis of psychogenic non-epileptic seizure. Of course, many a patient who has psychogenic non-epileptic seizure may be also on anti-epileptics, and true seizures may be covered. Hence, whenever you see a psychogenic non-epileptic seizures and before you decide to stop or taper the anti-epileptics, please ask and rule out whether they had any seizures in their past history. Many a time, to differentiate this, you may have to also do increased prolactin levels. That means prolactin levels to be done. How to do that? Serum prolactin levels are usually taken immediately, approximately 5 to 20 minutes after the so-called episodes. That too, JTCS. If the patient has generalized tonic-clonic seizure type, and within 20 minutes you need to take the serum, and you will, after that, the serum prolactin level within 1 hour it starts declining. And be very clear, it has to be taken 20 minutes after the generalized tonic-clonic seizure. This peak value again should be compared after taking a second sample after 90 to 120 minutes to establish, yes, there is a falling titer. But however, remember, this prolactin level may also increase in syncope. Hence, it has a lesser utility value to differentiate between seizure and syncope. But however, you'll be able to differentiate between GTCS and TLE, and many a time between GTCS and psychogenic epilepsy. First and the foremost, you need to look for the organic causes, find what is the organicity, treat the cause. Especially if the patient has organic insult to the brain, maybe like cerebrovascular accident, especially in the frontal lobe. Once it happens there will be a decline in the personality. He may lose coping skills, and he may have psychogenic epilepsy at the age of 60 also. Checks for comorbid presence of epilepsy before you stop anti-epileptics. Establish the diagnosis of psychogenic non-epileptic seizures, rule out true seizures in the past, and also look for comorbid conditions. That is very essential. And many a time, to know whether it is a psychogenic epilepsy, you may have to do induction protocols. These induction protocols are highly challenged. Many of the psychiatrists and neurologists say it is inhuman, unethical to do this test. But however, some of the physicians do continue to do this test. Many a time in the emergency, they do this induction protocol. This is for the sake of academics I am presenting here. Many a time, the neurologist or the physician may tell, I'll be giving some IV fluids which will facilitate the occurrence of seizure. So they will start giving intravenous saline, or else sometimes they will keep the tuning fork on their forehead and they will say this will facilitate in getting those seizures. Sometimes they will do head tilting up and they say, yes, you are going to get this seizure now. That means they will be suggesting the patient to have these seizures. Many a time, unexperienced or inexperienced physicians will use ammonia cell test or smell test for aversion stimuli. They are using it whenever the patient has continuous epileptic attack, and or to abort the NPS, that is psychogenic epilepsy, they use it. I would recommend not to use this ammonia smell test. Further, you may also consider doing induction test in the when you are recording EEG. When you fail to get 48-hour video EEG, you don't get any episodes, then you may consider doing this photic stimulation or hyperventilation. Please do this in a place where there is IP setting is there, and if the patient gets epilepsy, you should be able to treat the patient immediately. Look for the comorbidity. Check whether the patient has comorbid anxiety disorder, whether he has depression, dysthymia, please consider starting escitalopram, that is selective serotonin reuptake inhibitor. Further, many a time with the acute psychosis or psychotic condition may also have dissociative symptoms, but however, there will be co-occurrings of delusions and hallucinations. In such a situation, you may have to start antipsychotics which have lesser propensity to cause seizures, such as like aripiprazole. And now you need to start working to cut down the secondary gains. As I mentioned earlier, the secondary gains are those the patient gets avoiding going to the job, decreasing their responsibility. So most of the time they are resting. The family gives undue importance. So in such a situation, we need to cut down those secondary gains. Educate the family and say that your patient is not having neurological epilepsy, but however, he has functional epilepsy. And that is a stress related epilepsy. But understand, don't increase the stress. Learn to ignore those episodes. Whenever he gets this episode, ask him to stay alone and tell him not to discuss these episodes with anybody else. If he discusses, the stress will increase. Further, the family members need to reward the patient whenever he has a normal behavior. That means you are doing a behavioral therapy, contingency management. Whenever he has episodes, no attention will be given. And when he is normal, the attention will be given. Further, identify those situations when he gets this episode. That means you are making the patient aware when he is going to get these episodes, and then he will apply relaxation and also increase the socialization of the patient. And finally, you need to consider for psychotherapy to resolve the primary gain. Invariably, many of these patients may have, as Sigmund Freud mentioned, immature sexual experiences which would have occurred at the adolescence, or else the grief which would have been unresolved may present like psychogenic seizures. So, especially when you are dealing with pseudo-seizures, involve the family members. And you need to educate the family by telling that after doing all the investigation, we have one good news, one bad news. Good news is he does not have neurological epilepsy, so he doesn't require anti-epileptics. The bad news is he has functional epilepsy, which requires therapy for longer duration. It may be psychotherapy or some kind of training he has to undergo. Further, stress management, cognitive behavioral therapy, mindfulness therapy. If there is frequent fights, family therapy also should be considered. And also you need to resume back to the work at the earliest. And sometimes the question will be asked whether a person with psychogenic epilepsy, should he drive, should he cook, or she can cook, whether he or she can get married. Such questions will be asked similar to epilepsy. At present, there is no legislation to address the issue with regard to driving privilege, whether they can socialize with regard to pseudo-seizures. Because pseudo-seizures means they are not true seizures, they are psychogenic non-epileptic seizures. So there is no hard and fast rule here. At the same time, we do not have research data from the perspective of pseudo-seizures, whether they can get married, whether what will happen in the future, whether they can drive or not, whether they can cook or not. We don't have this. So you need to advocate for individualized decision making. You need to help the patient and family members to take their own decision because they are not true seizures. Finally, what are the predictors of poor outcome? First and the foremost, very well established is duration of illness. If the illness is very chronic and he has psychogenic non-epileptic seizures since past 8 to 10 years, it is very difficult to treat because he has learned this habit of coping by using pseudo-seizures. Further, if the patient have comorbid seizures, true seizures, intellectual disability, personality disorder like borderline personality disorder, anxious avoidant personality disorder, chronic sexual abuse, or else PTSD, chronic depression, all these patients will have poor outcome. And what is that poor outcome? 1/4 of the patients will not improve. That is, 25% of the psychogenic non-epileptic seizures do not improve. But however, there are certain challenges in treating these patients. First and the foremost, refusing to accept the diagnosis that they don't have neurological epilepsy. Many a time, the doctors, neurologist, physician, even psychiatrist have a poor communication with the patient and the family. Many a time, the doctor will say, he is malingering, these are all drama seizures, these are all not true seizures, he is crazy, these episodes are occurring in the brain, and so forth comments are made. This will lead to poor compliance for treatment. Many of the physicians will use ammonia sniffing or smelling test with the patient, which breaks the ethical values. Further, there are no access to mental health care in many of the developing countries. How will you do psychotherapy, especially with psychogenic non-epileptic seizures? Non-availability of video EEG, no time to ask for history, and not involving the family member in the treatment, and availability of psychotherapy everywhere. So these are the major challenges in treatment of psychogenic non-epileptic seizures. To conclude, my dear friends, pseudo-seizure is a challenging phenomenon to any physician. Here, the comorbidity is the rule. Whenever you establish a psychogenic non-epileptic seizure, check for psychiatric comorbidity and also neurological comorbidity, especially he or she may have true seizures also along with the pseudo-seizures. Hence, before you decide to stop the anti-epileptics, please rule out whether he had seizures in the past. Hence, a good history taking, EEG, and if required video EEG should be help you to manage the patient. And again, serum prolactin levels can be considered, but it has a limited role, especially if the patient has syncope. And also in TLC, the sensitivity of this prolactin level is very poor. Hence, prolactin level is plus or minus according to me. Identify the cause, explore the comorbidity, and treat the comorbidity. And make attempts to remove the secondary gain by involving the family members, and to remove the primary gain, involve the patient in long-term psychotherapy. Educate the family by telling there is a good news and bad news, and help the patient to digest the diagnosis. And finally, when you treat a patient with psychogenic non-epileptic seizures, multidisciplinary team is required. That means there should be a constant communication between the neurologist and psychiatrist to how to deal these patients. Thank you very much for giving your valuable time. Stay safe.